up? So this is your student nurse Lester. For today's video, I'll be making a new video, and that video that I will be making will be all about tuberculosis. Disclaimer, this video is for learning purposes only. So let's go.
First, before we delve to our discussion, we will tackle all of the overview of the infectious process, definition, transmission, etiology, risk factors, pathogenesis, pathophysiology, types, clinical manifestation, assessment and diagnosis, laboratory and diagnostic procedures, medical management, pharmacological management, surgical management, nursing diagnosis, nursing management and responsibilities, and lastly is the prognosis. The infectious process has chain of infection, and the chain of infection is composed of 6 elements that are necessary for infection to occur. Number 1 are the causative organism. Number 2 are the reservoir of the available organism. Number 3 is a portal of mode of exit from the reservoir. Number 4 is mode of transmission from reservoir to the host. Number 5 is the susceptible host. And number 6 is the mode of entry to the host. And there is causative organism composed of bacteria, ricochet, viruses, protozoa, fungi, and helminths. And in the chain of infection, there are infectious agents such as bacteria, fungi, ricochet, viruses, and protozoa, which can be intervened by rapid, accurate identification of organism. And in the reservoir, such as people, equipment, water, and the intervention would be employees' health, environmental sanitation, disinfection, and sterilization. And in the portal of exit, where there is excretion, secretion, skin, or in droplets, and interventions would be hand hygiene, control of excretion and secretions, and trash and waste disposal. And in the means of transmission, where in the direct contact, ingestion, formalities, airborne, and the interventions would be isolation, food handling, airflow control, standard precaution, sterilization, hand hygiene. And in the portal of entry, where in the mucous membrane, gastrointestinal tract, genitourinary tract, respiratory tract, or in a broken skin, would be the interventions are the wound care, catheter care, and aseptic technique. And in the susceptible host, which is immunosuppression, diabetes, surgery, burns, and in elderly, which has the interventions of recognition of high-risk patient and the treatment of the underlying disease. So, the definition of tuberculosis from a Neo-Latin word, from the word tubercle, which means round, nodule, or swelling, and the osis means the condition. The definition speaks itself that it is a chronic, serious, and contagious bacterial infection caused by Mycobacterium tuberculosis that is characterized by the formation of granulomas in infected tissue and by cell-mediated hypersensitivity. Then, the disease is primarily affecting lung parenchyma, and it may spread to any part of the body including meninges, kidney, bones, and lymph nodes. So, means of transmission is the TB spreads from person to person by airborne. An infected person releases droplet nuclei through talking, coughing, sneezing, laughing, or singing. Then the etiology would be it is a slow growth bacteria, characteristic lipid-rich cell wall, no environmental source, which is specific to human pathogen. Relatives are non-tuberculosis mycobacteria. Environmental species can cause similar disease to TB, but it is rare. Then subspecies of tuberculosis would be M. bovis in animals, M. africanus, BCG, or such a laboratory modified. The Mycobacterium tuberculosis. It is a rod-shaped obligate that is aerobic intracellular pathogen. Then it is grows very slowly. The cell wall is lipid rich called mycolic acid. Do not stain with gram stain. Then it is manuscap glycolipids enable to bind macrophages. Then it is able to survive and multiply inside macrophages by avoiding lysosomal killing. Next is it is acid and alcohol fast bacilli and does not decolorize with acid or alcohol when stained with Ziehl-Neelsen stain. The natural reservoir of the Mycobacterium tuberculosis is human, and it is transmitted through airborne. And the Mycobacterium tuberculosis is sensitive to heat because it is destroyed by pasteurization, and it is sensitive also in UV light and chemical substances such as alcohol, formaldehyde, and glutaraldehyde. The Mycobacterium tuberculosis will be affected in the lungs, liver, intestines, kidney, brain, bones, eyes, and the skin. The risk factors of TB would be HIV infection, which is a serious risk factor for TB because of the pathogenesis of TB depend on the host immune response, alcoholism, and drug abuse, immunosuppressive therapy such as a treatment of corticosteroid, diabetes mellitus, chronic renal failure, recent surgery. Also, risk factors are the workers in health facilities such as doctors, nurses, laboratory technicians, tight living quarters or overcrowded substandard housing, below or at poverty line, refugee or immigrant, immune system issue, kids under 5 years of age, and lastly is the elderly. The pathogenesis would be the TB would be inhaled in droplets coughed out by patient with active TB. Then it invades the macrophages and diverts normal phagosome pathways. It helps spread within body and immune evasion. It allows long-term persistence, which is called the latent disease, and it stimulates histological immunological hallmark of granulomas. Then it's lifelong survival inside the macrophages, which is also called the latent disease, and active disease mainly lungs or pulmonary TB but can spread to affect almost anywhere, called as extrapulmonary TB. Then the pathophysiology of the tuberculosis is initial infection or primary infection from Mycobacterium tuberculosis, which is entry of microorganism through droplet nuclei by sneezing, laughing, coughing, and singing. And the bacteria is transmitted to alveoli through airways where the deposition and multiplication of bacteria occurs. Then the bacilli are also transported to the other parts of the body via bloodstream and phagocytosis by neutrophils and macrophages. Then the microbacterium will lodge into the pulmonary alveoli. Then it causes and called alveolar macrophages. Then it detects the presence of pathogens and engulf the bacteria. Then the mycobacterium bacteria inhibit the macrophages to form phagolysosome and remains protected inside the macrophages. Then it starts the replication inside the macrophages. Then the primary infection occurs, then it is cell-mediated immunity is activated, surrounds the cell to form granulomas within 3 weeks. Then it leads to necrosis to tissue infection sites termed as Gon's focus. Then it involves nearby lymph nodes, which also termed as CoN complex. Then calcification of CoN complex will also called as the latent TB, which if the latent TB is untreated, it will undergo or may cause active TB. So to fully understand the pathophysiology of the TB, I would like to show you a short video clip on how the physiology goes.
Tuberculosis, also known as TB, is spread through the air from one person to another. When someone with pulmonary TB disease coughs, TB bacteria are expelled into the air in tiny water droplets. These droplets can remain floating in the air for several hours, making it possible for someone nearby to inhale them. Once a person has breathed in droplets that contain TB bacteria, they travel down the trachea and enter the lungs, where they collect in the alveolar sacs. Once in the alveolar sacs, the bacteria begin to multiply. The body's immune system starts working and macrophages begin to surround the bacteria. A granuloma is formed to keep the bacteria from spreading. The TB bacteria remain in the lungs, but the body is protected from disease by the granuloma. In 8 to 10 weeks, the person will most likely test positive for latent TB infection. The progression from latent TB infection to TB disease occurs when the granuloma break open and the TB bacteria multiply. Then the person becomes sick with TB disease and may be infectious. This progression can occur immediately after infection, many years later, or not at all. When the TB escapes from the granuloma and begins destroying a person's lungs, it's called pulmonary TB. TB bacteria can also enter the bloodstream and travel to other parts of the body, causing extrapulmonary TB.
So next is the types of TB, which has two types. The primary TB, which is non-sensitized host, and the post-primary or secondary TB, which is insensitized host. Then the spectrum of disease based on the immune response of the host, which is the active TB, where it is multiplying the bacilli. Then it has pulmonary TB, extrapulmonary TB, and the miliary TB, which is in the bloodstream with high bacillary load. The latent TB is a bacteria remain in the body in active state. They cause no symptom and are not contagious, but they can become active. And the active TB bacteria, though, cause symptoms and can be transmitted to others. So in the primary pulmonary TB, the inhalation of M. tuberculosis or the Mycobacterium tuberculosis, which is a bacilli get lodged in the upper part of the lower part of the upper lobe subpleurally. Bacteria are engulfed by the alveolar macrophages. Then the macrophages response, which cause inflammation, and it is termed as Gun's focus. Then the Mycobacterium tuberculosis survive inside the macrophages by avoiding lysosomal killing. Then the multiplying in the macrophages, or also called as bacillary proliferation, within the first 3 weeks. Then the bacteria spreads via lymphatics and bloodstream to the other parts of the body. Then the bacilli taken to the lymph nodes via lymphatic. Then it becomes inflamed at the lymph nodes, and the macrophages present processed mycobacterial antigen to CD4 T cells. And the T cells become T helper cells, which is the interferon or IFN, which activates the macrophages, and the IL-2 or the interleukin-2 that activates other lymphocytes to become helper T cells. Then the primary pulmonary TB is asymptomatic or mild flu-like illness. Then possible outcomes, it will progress to primary TB if untreated. Then the most often resembles an acute bacterial pneumonia. Pleural effusion, lung collapse, and cavitation is also rare, and a lower and middle lobe consolidation. Then the dissemination of the bacilli via lymphatics and bloodstream will cause miliary TB, TB meningitis, TB lymphadenitis, TB spine, or the Pott's disease. Then the secondary pulmonary TB may arise shortly after primary TB, and this more commonly occurred decade later than the primary TB because of reinfection or entry of the Mycobacterium tuberculosis and reactivation of the dormant bacilli. Then, it involves the apex of the upper lobe of one or both of the lungs. Then, because of the pre-existence of hypersensitivity, regional lymph nodes involved is less prominent, and it heals by fibrosis spontaneously with treatment. Then if untreated secondary TB, it will progress to secondary TB, which will occur in the erosion into the bronchial wall and leakage of the content into the airways, which is also called as cavitation. Then the dissemination of bacilli through airways will spread into the other lobes, trachea, larynx, and it will cause also intestinal TB. The miliary TB, which is characteristic appearance like millet seeds, which is a bacilli draining through the lymphatics, will go through the venous blood and it lodges into the lungs. Then the systemic miliary TB, which is a bacilli disseminate through arterial blood in the liver, spleen, meninges, bone marrow, kidney, adrenals. Note, miliary TB is extremely fatal if untreated, high bacillary load with high ineffectivity. In extrapulmonary TB, it occurs in organ other than lungs. It can involve several organs, such as in the TB lymphatics, which is the commonest form, TB meningitis, Pott's disease, renal TB, and intestinal TB. The clinical manifestations in the intrapulmonary, which has two symptoms, it is classic symptoms such as chronic cough, it is dry or productive, progressive pulmonary involvement, increasing amounts of sputum, mucoid to purulent, hemoptysis, aggressive disease, that is invasion of the blood vessel, and pruritic chest pain, which is an extension of the infection of the pleural surface. And the systemic symptoms has low-grade fever, which is remittent, it appears late afternoon and fades out, and anorexia, inhibitory action of cytokines on the hypothalamus, which the patient has no appetite, and since there is anorexia, there is weight loss, and clinical manifestation in intrapulmonary includes night sweats. Then the clinical manifestations in extrapulmonary would be cervical or other site of the nodes will be smooth, firm, palpable nodes. In the GI, it is manifested by pain, bloating, or ascites. Then in a pericardial, it is constricted pericarditis. In the meninges, it can cause chronic headache, focal neuralgia, which can lead also to coma. In a miliary, which can cause weight loss. Then in a bones and joint, it manifests by painful mass swelling and can form also discharging in the sinuses. The complication of pulmonary are hemoptysis, pleural effusion, empyema, pneumothorax, aspergilloma, endobronchitis, bronchiectasis, laryngitis, cor pulmonale, CA bronchus, enteritis. Then in the extrapulmonary would be meningitis, spinal pain, joint damage, liver and kidney damage, heart disorders. Then the complication, which is in the hemoptysis, it is the usual in advanced disease. If it is moderate, inflammation will lead breakdown and cause diabetes. If it is massive, it is the erosion of the arteries in the necrotic area. Then the bronchiectasis, it occurs due to weakening of the bronchial wall by tubercular granulation tissue and past tubercular fibrosis. Next complication is the pleural effusion, which is manifestation of mycobacterial infection within the pleural space, which is acquired from initial parenchymal lesions and results in delayed hypersensitivity reaction to the mycobacteria or mycobacterial antigen in the pleural space. Next is the pneumothorax, which is spontaneous pneumothorax, the rupture of the subpleural tuberculosis lesions, which is manifested by acute chest pain, tightness, marked respiratory distress, tachycardia, and cyanosis. Pulmonary aspergillosis, it is manifest as simple aspergilloma or fungal ball or a chronic cavitary aspergillosis, which is manifested by cough, hemoptysis, and wheezing. It is a air present sign or what we call fungal ball. The core pulmonale, it is a extensive lung destruction which causes scarring and the destruction of the pulmonary vasculature, tuberculosis, and arteritis and vasoconstriction. And the tubercular endobronchitis is direct implantation of bronchi within the TB bacilli in the sputum, and its degree of obstruction which causes cough, expectoration, wheeze, and hemoptysis. Tuberculous enteritis, which is the secondary to pulmonary tuberculosis, usually in the ileocecal area. And the signs and symptoms would be abdominal pain, alternating diarrhea, and constipation, loss of appetite, and weight. The assessment and diagnosis of TB is it's primarily based on history, signs and symptoms, and radiographic findings. Where there is clubbing of the fingers or toes, swollen or tender lymph nodes in the neck or other areas, then pleural effusion and crackles. Then ask about contact history and physical status before the commencement of cough. Then findings in miliary TB would be swollen liver, lymph nodes, and spleen. Then the laboratory and diagnostic procedures on the latent TB would be Mantoux test, also called a screening method or the tuberculin scan test, where there is 0.1 cc or 5 units of purified protein. It is injected intradermally. The test is treated 48 to 72 hours later by measuring diameter of induration. A positive test for TB exposure is defined as 5 positive millimeter if HIV positive recent contact with active TB cases, severely immunocompromised, or by an organ transplant. Then the 10 positive millimeter if immigrated less than 5 years, high prevalence country, injection drug user, resident or employee of hospital, prison, nursing home, homeless, shelter, military, moderate immunosuppression such as diabetes mellitus, leukemia, in stage of renal disease, and in steroids, and also the children below 4 years old. And in 15 millimeter positive, no known risk for TB. Next is the quantiferon TB gold or the single blood sample 24-hour turnaround interferon gamma release assay or IGRA. The test measures interferon gamma in the testis blood or the patient after incubating the blood with a specific antigens from Mycobacterium tuberculosis. In the active TB, which includes the chest X-ray, chest CT scan, bronchoscopy, biopsy of extrapulmonary site after microscopy, and culture. These are the results of the laboratory in the patients with TB. Next also is inactive TB, which is thoracentesis, 3 sputum direct smear for acid fast bacilli or AFB, stained in bright red with Ziehl-Neelsen stain, and it is needed to be 3 sputum samples, especially in early morning is the best. Then the mycobacterial culture will be 4 to 12 weeks result. And lastly is the PCR or the polymerase chain reaction. It is rapid detection and can detect antibiotic resistant genes. The medical management would be nutritional therapy, lifestyle modification, crop hygiene, regular follow-up, prevention of complications. And also, that's are the directly observed treatment short course, especially critical for patients with drug-resistant TB, HIV infected, and patient intermittent treatment regimens, which are the multiple drug therapy such as pyrazinamide that bacterial effects that can kill the bacteria. And the nursing management would be watch in patients who are diabetic, have kidney problems or gout, then monitor uric acid levels, liver and kidney function, then also monitor GI upset, which is common, and it is advised to the patient that it will be administered with food. Then next is the ethambutol, which stop RNA synthesis, which is a bacteriostatic that prevents from reproducing. Then the nursing management would be assess the for eye assess for patient's vision, peripheral neuropathy, or damage to nerves, then it is signs and symptoms of numbness or burning in the extremities, and always assess for this as well. Next is isoniazid that kills bacteria and stops its growth. It decreases the vitamin B6 levels, and the nurse must monitor liver function and neurotoxicity. The streptomycin stops protein synthesis and kills bacteria, and the nurse must monitor hearing. Then the rifampicin stops RNA polymerase that kills bacteria, and the nurse must observe that the body fluids turning orange and will stain soft contact lenses. Then advise the patient to wear hard lenses possible. The note, birth control is less effective than the patient get easily sunburned, and the medication would be administered then no alcohol or beverages during the medication, and signs and symptoms would be jaundice and with bleeding. Then the pharmacological management, standard treatment for pulmonary TB within a 6 months treatment with antibiotics. The anti-TB drugs are restricted and highly supervised use. These are the first line anti-tubercular medication. Number one is the isoniazid, which is taken orally and intramuscularly that kills mycobacteria relatively rapidly. Next is the rifampicin, which is orally taken and it kills slowly replicating mycobacteria. Pyrazinamide, which is also orally taken within first 2 months only. And the ethambutol, it's also orally taken and it's also first 2 months only with test to the eyes. And streptomycin through intramuscular. The secondary line of medication are the capreomycin, ethionamide, para-aminosalicylate sodium, cycloserine, vitamin B, or the pyridoxine that is administered with isoniazid. The surgical management of tuberculosis would be the recommendation was for the use of partial lung resection, lobectomy, or wedge resection. Alongside the provision of medication, a lobectomy is a type of surgery mostly used for lung cancer in which one lobe of lung is removed and a lobe may be removed to prevent the spread of TB to another lobe. These are the surgeries that been done. The first is the lobectomy, pneumonectomy, wedge resection, then the segmentectomy. The prevention of TB would be in isolation of the infected people, which given as a spatial ventilation and negative pressure room, contact tracing and screening in healthy population, cover mouth and nose when coughing and sneezing, wear mask that is a N95 mask. Then early detection and treatment, vaccination, such as BCG vaccine, then live attenuated vaccine, or the BCG, or the Bacillus calmette-guerin that reduce virulence of type of M. bovis, then given at birth for prevention of miliary TB and TB meningitis. The nursing diagnosis would be an effective breathing related to pulmonary infection and potential for long-term scarring with decreased lung capacity. Next is risk for impaired gas exchange. Next is risk for spreading infection related to nature of disease and patient's symptoms. Next is imbalanced nutrition, less than body requirement related to poor appetite, fatigue, and productive cough. Plus is deficient knowledge about treatment regimen and preventive health measures related to ineffective individual management of therapeutic regimen or non-compliance. The nursing management would be assessment to the patient, obtain history of exposure to TB, assess for symptoms of active disease, auscultate lung for crackles. During drug therapy, assess for liver function, promoting airway clearance, advocating adherence to treatment regimen, and last is promoting activity and adequate nutrition and preventing the spread of TB infection. The prognosis would be in immunocompetent patients with drug-susceptible pulmonary TB, even severe disease with large cavities. Appropriate therapy is usually curative if it is instituted and completed. Then TB causes or contributes to death in about 10% of the cases, often in patients who are debilitated for other reasons. Then disseminated TB and TB meningitis may be fatal in up to 25% of cases despite of optimal treatment. And TB is much more aggressive in immunocompromised patients, and if not appropriately and aggressively treated, may be fatal. So that's all. So thank you for listening.
So that's all, guys. Thank you for watching. I hope you learned something. And don't forget to like, share, subscribe, and hit the notification bell for more upcoming learning videos. See ya! Bye!